what I'm talking to you about, almost nobody in the field knows anything that I'm saying here. And how do I know that? Because they're not using these techniques in their clinics. If they understood what I'm saying, they would be transitioning over to this immediately.
Professor Seyfried, there has been so much money invested on the war against cancer over the years. In research, people have been fundraising, trying to raise money to, continue to do research to try and find the cure. We've made very little progress given what we've been doing and the energy and money invested. Why do you think this is?
Well, thank you, Jesse. Listen, according to the National Cancer Institute, American Society for Cancer, we've made big progress. Okay, so we've dropped cancer deaths by 37%. So they consider we're making big progress. American Cancer Society out of Atlanta, Georgia. So in the 1990s, early 1990s, we really instituted the anti-smoking campaign. So people stopped smoking because they realized it put them at risk for cancer. And the big drop, or the great advantage that everybody is talking about, how much wonderful advance we made in cancer, is that the projection, had we not stopped smoking, we would have a lot more dead people from cancer today than we had in 1990. So what you do is you run out that trajectory to 2023 and say, oh, if we continued to smoke, we would have had a lot more cancer. So the fact that we stopped smoking, we actually reduced the number of cancer deaths by 35% or whatever it is. But it's a projection from prevention, no advance from any therapeutic treatments that were given. So most of the great advance in cancer over the last 30, 40 years came from the people not smoking. Now, the other problem we're having today now is that obesity is replacing cancer as a number one risk factor for the problem. So we're back to almost where we started from, and we're not making any real progress. The problem is that there's a misunderstanding about what the nature of the disease is, and this is the real issue. It's not so much smoke and mirrors as what the cancer societies like to use. It's the failed recognition that cancer is a metabolic disease. It's not a genetic disease. So when you look at the treatments that you see for cancer patients, what are these treatments? Chemo, radiation, and some of these new immunotherapies. And we hear new drugs all the time being developed for cancer. And yet the more drugs that we develop for cancer, the more cancer we get. So there's something seriously wrong here. And if you look back at the drugs we're developing, they're all based on the somatic mutation theory of the disease, which is cancer is a disease of somatic mutations. And that, we have drugs that are precision medicine, targeted therapies, and all this kind of stuff. They make it seem like this is going to be the solution to the problem. It's not. Because the disease is not a genetic disease. So most of the stuff that we're using is largely irrelevant, and it's toxic, it hurts the patient, costs a lot of money, and it really doesn't do the job that you'd expect it to do. Of course, there are a few people that respond really, really well, and we use those people to justify why we need to continue with this kind of strategy. But in the long run, it's not going to help the majority of cancer patients that do end up dying, suffering from the treatments. So, and that has to do largely with the misunderstanding of what the underlying mechanism is for the disease. And as I said, it's a metabolic disease that's driven by two fuels, the sugar glucose and the amino acid glutamine. And these two fuels are the ones that drive the dysregulated cell growth, which is ultimately the definition of cancer. So when people say, what is cancer? It's dysregulated cell growth, cell division out of control. What is it driven by? It's driven by a form of energy that doesn't require oxygen. Oh, yeah? Well, what doesn't require oxygen? Well, fermentation mechanisms. Oh, yeah, what's that? Well, you use fuels that don't require oxygen. What are these fuels? These fuels are the sugar glucose and the amino acid glutamine. Wow, that seems simple. How come nobody's targeting these fuels to manage cancer? Because they think it's a genetic disease, not a metabolic disease. Not that complicated.
You mentioned early on how all the progress being made, or at least the majority, is when it comes to prevention because people aren't smoking as much. The doctors that are giving these treatments and the researchers who are coming up with these drugs, do you feel like they feel in their hearts that they're making progress, or are they oblivious to what you're talking about there, where it's just a smoking factor?
Yeah, well, I think they intrinsically know. I mean, they're the guys treating the patients. Of course, they have some success, but they also see a lot of failures. And but they're told what to do by the AMA, American Medical Association. The standard of care is like written in granite, and their job is not to question the standard of care, but to follow the rules of the standard of care. Which then, if you come in with lung cancer, breast cancer, colon cancer, bladder cancer, they have a protocol that they use to treat that. Surgical first, perhaps, radiation, perhaps, a treatment program for some drug, and there, by the grace of God, you survive. But a lot of people don't survive, and that's why we have over 1,600 people a day, every single day, dying from cancer in this country, and it's over 8,000 a day in China, and it's rampant throughout the world. And they're talking about cancer replacing heart disease as the number one killer of people on the planet for a disease basis. So if they're already recognizing that cancer will overtake heart disease in the next year, and in fact, in China, it already has overtaken heart disease, that tells us that they're making no progress. Because if they were making progress, heart disease would remain as the number one killer, but cancer is now ready to overtake heart disease. So if we're making so much progress about the smoke and mirrors and all this other stuff, why we have so many people dying from cancer? 1,600 people a day dying. Think of all the people that are massively suffering from the treatments they received from this. If you had something successful, you would be able to drop the death rate. Even President Biden, in his State of the Union speech, he wants to drop cancer death rates by, I don't know, 50% in 30 years. We can drop that. We can drop that in 5 years, knowing what we know about the origin of cancer as a metabolic disease. Those numbers are easily achievable if you switch the paradigm. It's not a genetic disease, it's a metabolic disease. So if we treat the cancer as a metabolic disease, yeah, we're going to get what President Biden wants in a lot faster time.
Well, the interesting thing is that you've been doing this research, you and your team and other teams, for years. And you've put together this case for what we're going to talk about today. And I'm just curious, what happens when you and your team release a paper in a major journal and it does simplify things? Again, what we're going to get into today. Like, how can that not get the recognition when it's so obvious that things aren't working the current way that they are?
Yeah, you should, the reasons, right? There's several reasons. Number one, the dogma. The dogma says cancer is a genetic disease, and we must stay the course. That's one reason. The other reason is lack of knowledge. Most oncologists never heard of what I'm telling you. They don't read they don't read these papers. So if you don't read the paper, how are you ever going to be told that what's right and what's not right? When patients who do have great success with metabolic therapy go back to their oncologist, the oncologist says, wow, that's really good. Continue to do what you're doing. Well, don't you want to know what I'm doing? Why I'm not like the rest of your patients? No, I don't want to know that. Just continue to do what you're doing. These are the kinds of responses. And then, most importantly, it's hard to get somebody to accept something when their salary depends on them not accepting it. So, and I think that might be one of the biggest challenges that we have. So it's not one thing; it's a group of things that prevent. And my papers are being read. Don't get it wrong. It's just they're not being cited. They're being essentially ignored.
If you want to learn how to implement the ketogenic diet and the Press Pulse protocol into your cancer management, just visit school.com/keto for cancer, the new community by our research analyst Johnny Rockermeyer. Within this new community platform, you can connect with other patients and learn from their experiences. You can also just search through the posts other members have already made. You will have access to our classroom section as well, which provides practical advice and tools for the best results. These sections cover all parts of the Press Pulse protocol that you should implement. Starting with the general scientific concepts by Dr. Thomas Seyfried, we will show you how to start the ketogenic diet, including which foods to choose and which to avoid. Additionally, we prepared a list of doctors specialized in metabolic therapy, as well as details about glutamine inhibition and hyperbaric oxygen protocols. So, take a look around at school.com/keto for cancer.
Well, where my curiosity is, just to go a little bit further into this, why isn't a journalist out there realizing that he could basically make his or her career from, printing an article that people understand in Time magazine and getting this out to the masses, and you could be the recipient of a Nobel Prize. Like there is so much potential here for somebody to decipher and sift this information in a major publication like Time magazine or the New York Times in a way people can understand it and grab onto it and start to get some momentum going.
Yeah, well, it's not that easy. When a journalist would hear what we're saying, they run off to MD Anderson, Sloan Kettering, Dana-Farber, and they ask the top oncologists, what do you think of this? There's no evidence to support that. Rather than looking at the data themselves. And why don't you ask the patients who were ask the multitudes of people that are surviving as the result of this. And don't think this is not going unnoticed. The documentary movie of the Cancer Revolution, which is under construction, part A has already been developed. And they interview dozens of people that were so-called terminal. I'm alive, I'm doing well, I'm alive, all back and forth. So how long will it take? And don't forget, most people prefer to watch The Bachelor rather than documentaries, right? I mean, you have to look at what people are watching. You think they want to watch a show on cancer versus a really exciting show about The Bachelor? I mean, that's where the mentality, that's where the mindset is. People have enough problems in their life. They don't want to be talking about cancer unless it affects them directly. And then when it affects them directly, where do they go? They go to the top medical schools. And then they ask them, what about metabolic? Oh, no. If metabolic therapy were real, I would have heard about it. Okay. Where are the clinical trials? Yeah, I can't believe anything unless I see a clinical trial supporting. You can't do a clinical trial on the kinds of metabolic therapy we do with double-blind crossovers. It would be immoral to do that. A person to do metabolic therapy, it's diet-drug combos, and you can't do the strategy the way it's being done currently in the pharmaceutical attempts to make drugs for clinical trials. So we have to redesign the types of clinical trials, compare it to what we call historic controls, okay? So for glioblastoma, the brain tumor, if you're surviving after 5 years, there may be 5 or 7% of people that get standard of care that actually survive 5 years. Okay, so we're not going to put in a group of GBM patients that get radiation and chemo, and as a matter of fact, they will not do the critical control group. And they do this for a lot of cancers. So we're going to use standard of care, which is radiation and chemo, plus metabolic therapy. Okay, how does that work? But where is your metabolic therapy group by itself to compare standard of care with metabolic therapy by itself? Can't do that, sorry. So the very system will not allow this stuff to get through the system because God forbid it works. Suppose the metabolic therapy people live a hell of a lot longer than standard of care or even standard of care with metabolic therapy. What's going to happen?
So correct me if I'm wrong. What you're saying here is the fact that we can't get a clean trial where we get to see metabolic therapy on its own because of ethics.
Yeah.
And
ethics.
What they're doing, or I'm not sure if it's you and your team or other researchers, but what we've been able to do is do standard of care chemotherapy, radiation, surgery, and then apply metabolic therapy after the body's been quote unquote trashed by those. And from hearing you talk on other conversations, it sounds like the therapy we're going to talk about today, because it is so effective, is able to help people even after their body's been trashed.
That's true.
At least in some instances.
Yeah, it is. You're absolutely right. In some instances, not all instances. Okay, there's some people, especially for glioblastoma. I mean, radiation liquefies your brain. So even you can't ask a metabolic therapy to stop the radiation from liquefying. It actually can help you, but it and the people that survive, and there have been a few studies that have been standard of care with metabolic therapy, who are in fact doing better. There's no question about it. But could they even do better? I think they can do massively better if you didn't irradiate the brain. I have shown in no uncertain terms that radiation of the brain is like the worst thing you can do to a brain cancer patient. Why? Because it frees up massive amounts of the two fuels that are absolutely necessary for the growth of those tumor cells and survival, the glucose and the glutamine. When you irradiate the brain, you free up massive amounts of glutamine, which fuel those cancer cells, make them resistant to chemotherapy and resistant to more radiation. And it's just like nuts. And no matter how many times that I write these papers in excruciating detail, describing in no uncertain terms how the radiation of the brain is causing the recurrence of the tumor and the death of their patients, you might as well be talking to a stone, because it doesn't have any impact on the people doing these kinds of treatments. So you have to look at it and say, wow, you're continuing to treat these people with a therapy you know does not work. And it may, in fact, lead to their demise. And yet you continue to do that over and over and over again. Why is that? What could explain another human being doing that to a person? And these are the kinds of things that nobody wants to touch with a 10-foot pole, because you have to change the standard of care. And the standard of care is like written in granite. And there's a lot of revenue to be generated from these standards of care. So until you come in with a business model that can replace the revenue from standard of care will maintain in place regardless of the outcome. And people say, how could you say that stuff? I says, why don't you look at the death certificates? Why don't you look at the survival curves from every major hospital in the world doing this kind of a therapy? It's abysmal. And yet they do it.
All right, let's get really granular here and talk about the metabolic therapy. So if somebody were to have a brain tumor, we'll use the glioblastoma like you mentioned earlier. We know glutamine and eliminating that, plus eliminating glucose is part of the treatment. Let's talk really again on a granular level what that looks like. How does somebody begin to do that through diet and drugs?
Well, yeah, the first thing. Now, the GBM, it's a call on the surgeon. They have to make a decision, because some GBM, if it's not operated on immediately, it could herniate and kill that patient very, very quickly. So everything is a judgment call on the part of the surgeon. A surgeon has to do MRI, a variety of different scans to evaluate where that tumor is, the size of it, if it's impacting. Not all the time, but many times you have a watchful waiting period before you have to have the tumor removed surgically. We're not against, there's thousands of articles, I wouldn't say thousands, hundreds of articles in the scientific literature showing that the more I can debulk, get rid of it, the longer the patient will survive. No question about that. The issue, of course, is that if you have a watchful waiting period, this is an angry mass. And I'm not talking, I could be talking about liver cancer. I could be talking about bladder, colon, lung. They all have a lot of inflammation in the microenvironment. A lot of it's kind of bloody and angry, inflamed, and all this kind of stuff. You want to reduce local inflammation as best you can, so that when you do the surgical debulking, you have more sharp edges around that tumor, and that when you do the debulking, you're going to get a lot more of the tumor than if you go after this tumor like a bull in a china shop, because you're going to create a mess. And that mess is going to elicit these tumor cells to invade and disseminate through the brain. So you really want to get as many tumor cells back into the central mass as possible. And you can do that by water-only fasting, extremely restricted ketogenic diets. You can get the inflammation in that to be less than it is. You make the mass less angry, less inflamed. Surgeon comes in, debulks. Already that patient will have an advantage to survive better, just because the surgeon was able to take more. How do I know that? Because we did the experiments here in the lab. we calculated all the bad blood vessels, the inflammation. We measured all the biomarkers and biochemical readouts for these things, and we can see it. The demarcation comes really sharp. Inflammation goes down. Angiogenesis goes down, which is abnormal blood vessel development. So you have all of the markers, and some of the tumor cells start to die. So all of this is really favorable therapeutic response if you have a watchful waiting period. So then the surgeon takes it out. And then after the surgeon would take it out, you would then transition back onto metabolic therapy. And there's a number of different drugs that we can use to facilitate calorie-restricted ketogenic diets, water-only fasting. These drugs are designed to specifically target the glucose and glutamine pathways in those tumor cells while not harming any of the normal cells of the body. So you don't have nausea, vomiting, diarrhea, hair loss, all this crazy stuff. You're going specifically at the heart of what those tumor cells need to survive. And then you hope for the best. And we're not like our one patient, Pablo Kelly, who has a website, he talks about his survival over 8 years now. His tumor is not cured. It continues to grow, but it was made indolent. So every 3 or 4 years, he has a debulking surgery and goes back about his life. So I think a lot of people think we should cure cancer. Of course, everybody would like to cure cancer. But the second best thing is learning to live with it. If you had a terminal cancer and you're not terminal, you might be at some point, but you're outliving by long periods what you would have been expected to live. What's wrong with that? So, in other words, can you have effective management with maintaining a high quality of life? And maybe you eventually will die from this tumor, but you won't die in the time frame that 98% of the people are dying, and you're going to live a lot longer. So the idea is this is a very new strategy for managing cancer. Is it perfected? No. Do we understand the problems? Yes. Can we design strategies to deal with the problems? Absolutely. So it's a work in progress, but in the end, you want GBM patients to survive a minimum of 5 years, not 2 people surviving after 5 years. You want at least half of the patients to be alive at 5 years. And that's not what we're seeing today. And I can go through the list of every major cancer: breast cancer, colon cancer, bladder cancer, liver cancer. They all have the same problem. They need glucose and glutamine. We found that. We know that. We know that. So it's a singular strategy, tweaked a little bit different for each type of cancer, but it's basically the same strategy. This is not what the industry wants to hear, believe me.
So when we go to cut off the glucose supply, which is feeding the cancer cell and allowing them to ferment and make more energy, you mentioned their water fasting and the ketogenic diet. I'm curious, for somebody who does decide to take on one of those as the dietary piece to address that part of the cancer, is there a difference in the research showing one being better than the other? Obviously, the water fasting is more extreme. Is it more effective to go that extreme?
No. We use the glucose ketone index calculator, which we published here. That gives every patient with cancer can then know how they stand. So it's a meter. You can buy it on Amazon, a Keto Mojo glucose ketone index meter, a meter that measures blood sugar. You prick your finger like a diabetic would. You measure with a strip. You can measure your blood sugar. You put the strip in the meter, reads the sugar. Okay, squeeze your finger a little bit more, put the ketone strip, put that in the meter. It tells you what your ketones are. You push the button and you get a ratio of how much ketone to glucose is in the blood. And normally, people would look at that right after their lunch or dinner or whatever, and you'd have a value of about 50 or 60. Okay, to manage cancer, you need a value of 2.0 or below. Okay, people say, oh man, I don't know if I can get that. They eat this and, can I eat that? Can I eat this? I don't know. Why don't you check your GKI, your glucose ketone index, and see whether you can eat that? And they said, oh no, it went up to 20. Well, don't eat that. So it's not that hard. And then they'll come and say, oh man, it's really, really hard to get my blood sugars down and my ketones up. And I said, well, I said, you want to kill cancer cells? What's your plan here? It's not easy. I don't want people to think. I'll tell you, it's a hell of a lot easier sitting down in the oncology thing and getting infused with poison. You don't have to do anything. You just sit in a lounge chair and they just drain it into your bloodstream. Doing metabolic therapy requires a big effort on your part. The patient has to play a major role in the management of the disease. Otherwise, it's not going to work. So when the patient can get down into that low GKI value, then the patient becomes now the next step is use specific drugs that work better against the glucose and glutamine together. So you got the diet on the one side, making you healthier, putting pressure on the tumor cells, but then you hit them with low doses of a variety of other, and some of that can be low dose chemo, by the way. And then you just start hammering these tumor cells out of existence. So, and degrade them slowly while you continue to be healthy. None of this hair loss, vomiting, and all this other stuff. The tumor cells cannot survive in these harsh metabolic environments. You're doing it by lowering your sugar, and then you take small doses of like repurposed drugs and things like we already listed some of these, and more of them are becoming recognized. So you don't need to spend a lot of money. Now, as I said, you don't need to suffer with a lot of toxicity. Is it easy? No. I know what I'd have to do, but do you think I'm going to be saying, oh, no, I can't eat donuts and rice and bread? Okay, well, that might be the part of your sacrifice. And what a lot of people do, they dovetail it in with prayer. Whatever religion they are, they pray, and that helps them avoid bread. And in other words, it gives them more motivation to participate in their own healing process. What we found is that the human body has incredible capacity to heal itself if given the opportunity. So when you give your body the opportunity to heal, it will heal. It's hard to heal when you're being irradiated and treated with drugs that are poisonous. It's hard for the body to rally against that. So I think we have to change this whole paradigm by the way cancer is treated, and we can get much better success than what we have currently today.
One point I want to highlight there, the fact that blood glucose is still going to be elevated to a point. Even if we're fasting, doing water fasting over a longer period of time, we're still going to maintain a relative level of blood glucose, which for me triggers in my mind, it's not like you're having rice or a donut and spiking that blood glucose, but you still have that baseline level no matter what you're doing. How is that not enough to facilitate fuel for the cancer cells?
Yeah. So it's a population dynamics issue. Okay. When you have a high enough level of blood sugar from eating carbohydrates or whatever, the brain is satiated. Most of the other cells in your body are satiated. You already have a massive amount of excess glucose because you're eating foods that produce glucose. So if you stop eating from foods that produce glucose, your body now has to replace the glucose with something else. And they mobilize fats, and the fats go to the liver, and the liver produces ketone bodies. But the liver will also produce glucose through the process of gluconeogenesis. But gluconeogenesis cannot make up the need for how much glucose your brain needs. So there's going to be a shortage. So what's going to happen then is your brain is going to take what little glucose is available to do its, and then replace the rest of it with ketone bodies. So this deprives the other cells in your body of glucose. And other cells in the body now also increase their demand for this glucose, because glucose is a good fuel for a lot of things. So now the tumor cells, which absolutely must have that fuel, are now competing with all other cells that also want the same fuel, but they wouldn't have competed with the tumor cells when the glucose was so high. So the tumor cells were free to do what they want to do. You lower the blood sugar, now these cells are in direct competition with other cells in the body, and eventually they start to lose the fight. They need the glucose. These other guys can burn ketones and glucose. These guys can't burn the ketones. They can't burn fatty acids. So they're linked to two fuels. One of them is glucose, and the other is this glutamine, which is an amino acid, which is the most abundant amino acid in the body. No diet can target the availability of the glutamine. That's why you have to come in with a little bit of a drug that will push that glutamine down, thereby starving these tumor cells of the two key fuels that they need. So you need to know how to play the normal cells off the tumor cells. You need to know how to reconstruct the energy, bioenergetic system in the body so that the tumor cells are now in a fight for their life, for their struggle, where the rest of the body can transition off to another fuel. This is the strategy that we can use. So the other thing you have to realize that no one denies is that all the tumor cells have thousands of mutations. Everybody knows that. They have mutations because their energy is inefficient. They perform these reactive oxygen species, causing mutations in the DNA. So when you have all these tumor cells full of genetic mutations, and now you're taking the whole body and putting it into an energetic restricted state. Normal cells evolved over millions of years to adapt to these restricted states. They make great efficiency at a small availability of molecules that can be respired in the environment. The tumor cell has all these mutations. It traps them. It prevents them from making rapid adaptations because the mutations block they have no metabolic flexibility. So that then puts them at a massive competitive disadvantage when they're up against the normal cells that have this metabolic flexibility. So you put all that together, lack of metabolic flexibility, restriction of the two fuels that are absolutely essential for their existence, and you target this while you're transitioning over, and these tumor cells are gradually eliminated and degraded slowly, and the material used from these dead tumor cells is now recycled into the normal cells of the body. The body will turn and eat the tumor cells as part of the fuel when you have under these. It's unbelievable. It's when you understand the bioenergetics of your body and what it's capable of doing, you know how these tumor cells can be blasted very effectively by just using a few strategies that is based on evolutionary biology and understanding of the biology of the tumor.
You talked about the genetic mutations within the tumor, and for anybody that might be confused, because early on in our conversation, we said that that's the current paradigm that doctors go by, the genetic mutations. Well, we're saying, we're not denying there are genetic mutations. It's the fact that we're going more upstream and saying that those are just a factor that happens later on, not the actual cause at the very top.
Yeah, they're completely correct. They collect, and the more the tumor is aggressive, the more mutations they collect. But those mutations also block metabolic adaptation. So as soon as you start restricting the two fuels absolutely essential for the growth of the tumor, the viability of the tumor, those tumor cells lack the ability to get energy from oxygen. That's the key. The tumor cell cannot get energy from oxygen. It can only get energy from what we call substrate level phosphorylation. It's a form of energy that doesn't require oxygen. Okay, so it's an ancient pathway. All the cells that existed on the planet before oxygen came into the atmosphere used this same energy mechanism, energy without oxygen. This is very interesting because tumor cells, as I said, what Otto Warburg did years ago with animals that had tumors, he would give the animal cyanide, which kills the animal immediately. But the tumor cells aren't killed. The tumor cells can grow in cyanide. They can grow without oxygen. So that clearly tells you these. So what are they? Wow, you mean to tell me a tumor cell can grow in cyanide? I said, yeah, we've done it. So cyanide kills people instantly, but the tumor cell is not killed by the cyanide. Why is that? Because it's not using oxygen. It's using ancient pathways to get energy. What are those pathways? Well, it's a fermentation mechanism. Wow. What are glycolysis in the cytoplasm, glutaminolysis in the mitochondria? So we know exactly what pathways these tumor cells are using. And I said, well, how do you know that? Because we targeted those pathways, kills the tumors right away. It's not that complicated. People, oh, wow, because the field is saying, okay, you got 10,000 mutations in there. Our precision medicine is going to target one of those mutations or a couple of them. That's not going to work. Each tumor cell has different constellation of mutations. So it's definitely not going to work. And it doesn't work for the majority of people. As a matter of fact, some of those targeted mutations turn on the body and blow out your liver, blow out your kidneys. They can kill you faster than the tumor can kill you. If you have the same epitope on a normal cell that you thought was only on the tumor cell, so when you give them this immunotherapy, it not only will hit a few of those tumor cells with that marker, but it also starts knocking out your liver and kidney that have that same mark. So what we see is called hyper-progressive disease. It's something you see when you see on TV at night all the commercials for all these cancer things, and on the bottom it'll kill you in 15 different ways. They make that that part real small. That should be the number one part. This drug will kill you in 15 different ways, but you might be one of the few ones that are lucky to survive.
It's a crazy world.
It's a crazy world, man, but you got to live with it,
Coming back to the dietary piece. So your research shows we either want to adopt a ketogenic diet or go to water fasting when it comes to fighting cancer. And we know what that's doing so far. We talked about it cuts off the fuel supply of the glucose to the cancer. My question is, when we get into that state of ketosis through either of those means, are the ketones themselves part of the therapy? Are they attacking or causing an environment that the cancer doesn't like?
Yeah, that's a good point. We tried that. The cancer cells can grow in the present. So as long as we have glucose and glutamine there, you can put ketones in there. Okay, you have to get to really, really high levels, like 10 millimolar, before the ketones might act as a toxic. And the human body, it's hard to get up to 10 millimolar. So most people are in 2 to 4, maybe if they're lucky, 1 to 3, up to 5 millimolar, maybe a little higher. The primary role of the ketone bodies is to enhance the energetic efficiency of normal cells in the body. So that's their primary role. Also, by elevating ketones, it allows the body to push blood sugars down as low as you possibly can get, because you can even shoot up insulin into a person who is in therapeutic ketosis. Like for example, if you take a person and shoot them up with a high dose of insulin, they go unconscious, they have an epileptic seizure, and possibly could die because you've removed all of the sugar in the blood immediately, so the brain has no energy and you go unconscious. If you take those same people and put them in therapeutic ketosis like Drenick did, this Dr. Drenick, and had their ketones elevated to about 4 millimolar, and then shot them up with a high dose of insulin, nothing. There was no effect at all. Why? Because the ketones were replacing the glucose as the fuel for the brain. So as long as you can transition, the brain can switch from glucose to ketone bodies. The tumor cell cannot switch from glucose to ketone bodies. Why? Because you need a good mitochondria. Mitochondria is the organelle that gets energy from oxygen. And that organelle is busted, inefficient and broken. Oxidative phosphorylation part of that organelle is broken. So they can't use ketones or fatty acids because you need a good healthy mitochondria to use those. So once you know the biology of the cancer cell and the biology of the normal cells, you just play one group of cells off the other in the correct metabolic environment, and the tumor cells lose every time.
When it comes to that experiment you talked about where somebody's in ketosis and they're able to use insulin to really bring that glucose down, was that just a thought experiment or has that actually been done? And
No,
if
it's
so,
done.
is that something that can be therapeutic to even cut off that fuel supply even more to the cancer cells?
It might be. I have the paper here, Drenick. Look it up. I couldn't believe it. He took all these really obese people, massively obese, and put them on a water-only fast for 21 days, brought their blood sugars down and their ketones up, and then shot them up with insulin, bringing the blood sugar down to 0.5 millimolar, 9 milligrams per deciliter. That's death for anybody that's not in ketosis. Those people are fine. They didn't even have any cognitive changes at all. So it was absolutely proven that you can do this. You can push blood, as long as you are in ketosis, you're protected against the effects of low hypoglycemia. You go to the hospitals and you say, oh, you got to get your cancer patients down to about 55 to 65 milligrams. Oh, no, that's going to kill them. You don't know about the ketone. You don't know how to do this. I mean, you guys are medical professionals. You should know how to play these organs and these systems off each other to be successful in the treatment of the disease. So getting back to your question about can insulin potentiation therapy be one of the procedures that could use? I don't know. I know some of our colleagues in Istanbul use it. Some people have said they've gotten really good results as the result of that. But you got to make sure your patients are in therapeutic ketosis, nutritional ketosis, before you would want to mess around with that. Also, you've got to realize that this is not a long-term situation. They showed how long does the patient survive in this very, very low glucose condition using insulin and you're talking about several hours. You're not talking about several days. In order to kill the cancer cells, you really need to apply the pressure constantly over a significant period of time, where they're gradually degraded and gradually broken down and gradually managed. Insulin will kill a lot of cells maybe right off the bat, but it's not going to be It's not going to be. I don't think it might be used occasionally, a little bit of a pulse, but I'm not going to bank using it. And also, you got to be careful. If your patients aren't in ketosis when you do that, you could run the risk of harm. There's a lot of things one has to be cognizant of before you would want to do that. But the answer to your question is, yeah, you can lower blood sugar down to almost zero with an insulin potentiation therapy while the patient is in ketosis, not when the patient is not in ketosis. You would never, ever do something like that.
The other potential challenge I can see with using that insulin with a cancer patient is the fact that we know that's a growth hormone. And I'm curious how, that might be able to affect the growth of cancer.
Well, as I said, you can't grow without energy. Energy is the key. You have two things. You have metabolites for growth, but you also have the energy. You can have all the metabolites in the world, but you don't have the energy to use them. You're going to die. So everything comes back to energy. So you have to have two things to grow cancer cells. You have to have energy and you have to have metabolites. So you have the metabolites and the energy, and you'll be able to grow these cells. So both the glucose and the glutamine not only provide the energy together, they also provide the metabolites. The nitrogen from glutamine is necessary for DNA and RNA synthesis and the synthesis of all amino acids. The carbons from glucose are absolutely essential for running the pentose phosphate pathway and providing the raw material for the synthesis of proteins, lipids, and nucleic acids. So you put all those, the carbons from those two fuels are absolutely essential for the growth of those tumor cells. They can't use anything else in any sufficient capability. And in order to grow an inefficient beast, a growing tumor cell, which is highly energetically inefficient, you have to have logistics. The supply of the fuels used for their fermentation mechanism have to be present in the environment in sufficient quantities to drive the beast, because you need a lot of fuel that is inefficient. Okay, so if that's the key, you have two fuels that are necessary, that are abundant in the microenvironment, and the cancer cell will be able to grow and be resistant to almost everything you throw at it. But if you take away those two fuels and clean up the environment, these cells now become extremely vulnerable for killing and management without toxicity.
Coming back to my question earlier about the ketones and if they have a therapeutic role in this, it gets me thinking about exogenous ketones. And I know you mentioned there it would have to be this really high level of ketones in the body before they would be toxic to cancer. I'm curious, has there been any research or testing done of using this exogenous ketones as a way of, an adjunct to therapy?
Yeah, Dom D'Agostino, my friend from University of South Florida, is developing these ketone supplements that you could possibly use. And what we're finding is that if you do get yourself into a state of therapeutic ketosis where your ketone levels are about 3 to 4 millimolar and your blood sugar level is maybe 50 or 60 milligrams per deciliter, when you take the ketone supplements, your blood sugar can be pushed to even a lower degree, and your ketones can be even elevated to a higher level. Again, putting more pressure on the tumor cells. But we haven't worked yet that into a therapeutic strategy. It's based on dosage, timing, and scheduling. And in order to fully take advantage of exogenous ketones, we need to follow more patients and measure their blood sugar and ketones while we are monitoring their tumor non-invasively, either by PET analysis or by MRI or CAT scan or some of these non-invasive ways, monitoring if there's a linkage between visible shrinkage of the tumor linked to levels of blood sugar and ketones in the patient. So we can then get more quantitative information with respect to that. And that, as far as I know, hasn't been done yet. Right now we're just in the process of how long can we keep a patient alive with a high quality of life based on our concepts. But it's going to take more clinical and preclinical research to get the exact answer to your question.
So we've talked about the dietary piece quite a bit now through the glucose half of the equation. When it comes to glutamine, let's talk about the different drug options there and the physiology of how that stops that fuel from being used by the cancer.
Yeah, well, there's several ways. Glutamine is the most abundant amino acid in the body, higher than any other amino acid in the bloodstream. It's an absolutely, they call it a non-essential amino acid because you can synthesize it from glucose. It's essential for neurotransmission in the brain, the glutamine-glutamate cycle. So it's a very crucial metabolite, amino acid in the brain for keeping our neurons firing in a correct way. It's an absolutely essential metabolite for cells of our immune system, like macrophages, T cells, and B cells. The cells of our immune system require a lot of glutamine. And of course, in our gut, the health of our guts, crypt cells, and all these kinds of cells in our intestines, they're also big users of the glutamine. So when you say, okay, we're going to try to target cancer cells also, the metastatic cancer cell is a big consumer of glutamine because the metastatic cell, as we and others have shown, is actually derived from an immune cell in our body called the macrophage. It's a fusion hybridization kind of a thing. So they spread through the body, but they also sit next to immune cells. They suppress immune cells, but they're also consuming glutamine. So how do we go after the glutamine in the cancer cell without harming the normal cells that also need the glutamine? So this is why we use the pulse strategy. Okay, so we press the whole body of glucose, raising ketones, lowering glucose as a constant press on the cancer cell. So they become less aggressive, more indolent, less inflamed. And then we take low doses of glutamine inhibitors that can inhibit any part of the glutaminolysis pathway, coming from the bringing into glutamine, metabolizing it to glutamate, metabolizing it to alpha-ketoglutarate, to succinyl-CoA, to succinate. There's a pathway. And this is the pathway by which the cancer cells use to get their energy. So we can hit that pathway at any one of these steps, but we have to do it in a very strategic way as to not harm normal cells that need that same pathway. So that's why we pulse small doses of this as we got the cancer cells in a metabolic chokehold, but we're not ready to kill them yet. But we got to hit them with a little pulse and eventually they'll expire. But you got to do it in such a way as to not harm. This is why you need a fundamental understanding of biology. You need to understand the biology of all the key players that are participatory in the eventual management of the disease. So you can't go in there like a bull in a china shop and just, pour chemicals and poisons and radiation and all this kind of crazy shit. You can get rid of some cancer like that for sure. But you really can do it in a hell of a lot easier way, more strategic and less toxic if you understand how to play these pathways off of each other in the different kinds of cells that are in the tumor microenvironment. And eventually you degrade the tumors down to a point where they become assimilated and used for fuel by the rest of the cells. So you're absolutely right. You can't throw a whole bunch of glutamine targeting drugs. Sure, you're going to kill some cancer cells, but then you're going to paralyze your immune system because once you kill a bunch of cancer cells, who's going to come in and pick up the dead bodies of the cancer cells? You got a whole bunch of dead corpses of cells where that tumor used to be. And if you don't get rid of them, bacteria can get in there, cause some infection. You got another problem on your hands. So you got to be able to do this in a logical, strategic way to get rid of the tumor cells. I mean, all of this becomes extremely comprehensible when you understand the biology of the key players that are participatory in the growth of this malignancy. So again, it's just that we've been doing this for a long time. We study the biology of all the different participants in the microenvironment. We study who's doing what in these cancer cells, why they're spreading, how can they not, how do we kill them? And we're seeing success in people and in dogs. We're starting to see success in our strategy, and it's just a matter of polishing it up and perfecting it to get a real strategic way of dealing with this problem.
So when it comes to order of treatment, correct me if I'm wrong, but it's to get into a ketogenic state before you start pulsing the dawn.
Mm-hmm. Yes, because we showed in our publications that we could get 3 times more glutamine targeting drug through the blood-brain barrier onto target when the drug would be administered under therapeutic ketosis. So if you try to administer the drug in a high carbohydrate diet, American standard diet or whatever, you only get a little bit of drug on target. Therefore, you have to use a lot more of the drug. And when you use a lot more of the drug, you risk the toxicity issues that can come with the use of any drug given in excessive amounts. So what you want to do is you want to make that drug super powerful in lowest doses possible. And that is what the therapeutic ketosis does. It allows small molecules to come right on target, low dose, massively more powerful than they would have been if they were not used. This is another thing. You got to understand the biology of the problem to make your success much greater than it would have been. Again, what I'm talking to you about, almost nobody in the field knows anything that I'm saying here. And how do I know that? Because they're not using these techniques in their clinics. If they understood what I'm saying, they would be transitioning over to this immediately. But they're not. Why? Oh, I never heard of this before. Oh, I didn't know about it. You go ask them. Oh, I didn't know. No, there's no evidence to support. Did you read the paper? No, I didn't read the paper. Then how do you know there's no evidence to support that? You can go right down the list. And you have to give these guys a break too. These oncologists, they were never trained to look at cancer this way. They're memorizing all kinds of stuff, knowing how to use chemicals and radiation so you don't kill your poor patient. They're not looking at the biological strategies for knowing how to kill cancer cells without toxicity. They were never trained in the medical schools to know how to use diets and drugs, combos of diets and drugs to manage these things. So it's a lack of knowledge, lack of training, no motivation. I mean, you put it all together and you don't get what I'm telling you. You don't get that applied in the clinic.
One of the big things that jumps out to me too, as you talk about doctors, is the fact that even if, say, they tune into an interview like this and become aware or read your book, they have the legal ramifications if they try something alternative like this. So the way I understand it, at least, and I'm no lawyer, is that they're sort of handcuffed in a way to follow a certain protocol, or the college is going to crack down on them. So that's another whole layer to this.
That's another whole layer. That's what I'm talking about. No flexibility in the standard of care. The standard of care was never written in granite. It's only supposed to be used because based on best medical practices and outcome, it should be used until something better comes along. Something better is here, but why now can you not use it? Then you have to say, oh, there's something other than patient outcome that must be underlying the lack of ability to use this new approach to managing cancer. So that becomes a different level of investigation. Why they don't want to do this? What are the real reasons for not wanting to do this? And I told you at the beginning, there's a number of reasons why people can't do that. The hospital administrators, you have to look at bottom lines and budgets and all this kind of stuff. I mean, you're going to bring in a treatment protocol that's not going to generate the revenue that you got from something else, then we got to reevaluate whether we want to do that or not. People say, wow, are you sure about that? Go ahead. Go find out why you can't use metabolic therapy as a standalone next to, oh, no, can't do that. Why? It doesn't go through the institutional review board. We have a group of physicians on institutional review boards that have to make the decision. They'll allow metabolic therapy under certain cases as long as it's done concurrently with the standard of care. The standard of care is your problem. So you got to get rid of the standard. It's not working. The standard of care for brain cancer, at least for glioblastoma, is not working. It's not working for advanced lung cancer. It's not working for advanced breast cancer. It's not working for a systemic metastatic cancer. The standards of care are not working, and that's what's killing the majority, allowing these poor people to be dead. So when are we going to shift this standard of care away from these toxic strategies, not based on the underlying biology of the disease? That's a question people have to ask themselves, right?
Well, this, like you said, ties back to what we were talking about earlier, the fact that therapies like you're talking about not only have to overcome the cancer, but also the conventional treatment that has to be stacked on top of it. So we're coming full circle here.
Yes, you're coming full circle. And the biggest thing they always say is ketogenic diet safe. Is metabolic therapy safe? They're always worrying about the safety issue. Are you kidding me? You're telling me that a calorie-restricted ketogenic diet is more harmful to the body than high-dose radiation and chemo? They should be asking whether radiation and chemo is safe, not whether a metabolic diet is safe. I mean, it's completely upside down, right? I mean, it makes no sense. Is ketogenic diet? We have thousands of little kids using ketogenic diet therapy for managing seizures, right? Thousands of kids all over the world using it to manage epileptic seizures. And now we try it in a cancer. Oh, no, we got to be careful. It might not be safe for the cancer patient because they relative to what? Radiation and chemo? I mean, the absurdity of some of these things is just beyond my comprehension.
Well, speaking of safety, that gets me thinking about diet, where we've talked about to this point where we're cutting things out, we're getting into ketosis, and then we're adding this drug in, which again triggers in my mind, how do we make this even less invasive and potentially safer? And that's instead of using the Dawn to have a food or a substance extracted from food that could do the same thing. So anything in that realm that you've discovered or anything promising where you could see a food or an extract from food taking the place of the drug?
Yeah, well, for glutamine, not yet. Now, we have a paper under review with a dog that has a malignant mast cell tumor on his face. And in some of my lectures, I've shown pictures of that dog. That was kind of a surprising case because the owner, what they call pet parent, brought the dog into the vet clinic, and they discovered under its lip it had a mast cell tumor. They did a biopsy on it, and it was a mast cell tumor. So if you look in the literature on mast cell tumors in dogs, that when they do genomic screens, they find all kinds of mutations in the cells in mast cell tumor. So it's like just about all the other kinds of tumors. You see all kinds of mutations. So they wanted to give the recommendation was chemo and radiation. These are the standard things that they would do. The pet parent said no, they didn't want to do any of that because the outcome would not always be guaranteed. And their pet would be injured. It would be very sick. They said this dog would be very sick, and your outcome may not be a cure. So she said, "Well, I don't want to do that. I'm just going to figure out on my own." So she went back. The owner, in fact, all this is written in the paper that hopefully it's under review right now. But some of the reviews are pretty good, so I anticipate that it'll be out at some point. She switched the dog to a raw vegetable diet. Okay. So for a little over a year, and the tumor grew much bigger, okay, on this raw vegetable diet. So clearly the raw vegetable diet was not working. And the tumor became very noticeable and large and started to invade local area, meaning that it is malignant. In fact, it was malignant by invading local tissue when it was first diagnosed as a smaller growth, and then the raw vegetable diet made it much bigger. Then she read our work and recognized that the dog is a descendant of the wolf. All dogs are derived from the wolf. What does the wolf eat? The wolf eats raw meat. The wolf can eat anything but vegetables. So they took all the vegetables away from the dog and gave the dog raw chicken, fish oil, a raw egg, and some coconut oil, small amounts, teaspoon, tablespoon levels. And the dog was calorie restricted and lost only about 8 or 10% of its body weight. And within 3 months, this big ass tumor was like gone, which was remarkable. And we used no drugs. There was no extra drugs used. It was purely diet alone that did this. And people are asking, well, if you're talking about the glutamine, how is it possible that this big tumor could be resolved in a relatively short period of time without additional drugs? And the answer is, we don't really know. All we know is that the tumor was growing rapidly and big, and the rapid change in diet caused it to resolve completely. And the dog, which was a pit bull, died at 15 years of age from heart failure. And the tumor never returned. The tumor was eliminated in 2015, and the dog lived to 2019. So clearly, it was of its cancer. The question is, how do you explain radical remission of this tumor without using the drugs that we think would be more successful? And the answer is we're not really 100% sure, but it comes back to the fact that those mast cell tumors cells are loaded with mutations, which, as I said, block metabolic adaptation. So the tumor cells with their mutations could not redirect their metabolism when the body was asked to be under a more restrictive metabolic state. Those cells were unable to adjust, and that's where these collection of mutations in the tumor cells could be our ally when we start to put the whole body under a restrictive state. Dogs have an incredibly capable adaptation to physiological stress. And if you have a cell loaded with mutations, that cell will not have those capacities and will be eliminated for fuel for the rest of the body. So this is what we call autolytic cannibalism. Can it happen in people? Probably for some kinds of tumors. Will it happen for a glioblastoma? I don't think so. But maybe it could. We don't know. But if it were me and I were the one to have colon cancer, bladder cancer, or whatever, I would certainly use some of the very non-toxic drugs that I know would push the diet to make it a little bit more powerful. I'm not going to risk my life knowing that I have drugs available that I can use that are not so toxic and that could push these cancer cells out of existence a little faster. Is it possible that I could go on a 30-day water-only fast, which people do, and eliminate the cancer? Yes, it's possible. I have evidence from clinicians who have emailed me and told me that their cancers were completely dissolved after 25 days of several water-only fasts like this. Well, this is really tough. I think most people would probably figure out, can I get that done a little bit easier? Do you have a drug that might be able to push it a little bit faster? And the answer is yes. If people want to try a 21-day water-only fast 3 times a year to get rid of their cancer, I'm not going to stop them. I've seen it work, but it's not. But if you told a cancer patient that, they think you were crazy. Even oncologists think you're crazy to recommend something like that. But it works. But I wouldn't say it's something that everybody is going to jump on, especially if they have an opportunity to lessen the stress. People don't. You feel, oh Jesus. But you can do all these things. Yeah, they work. I mean, probably work on some people. Worked on Guy Tannenbaum. He's on the web. He did all these water-only fasts. He got rid of his advanced prostate cancer. So I'm not saying that's going to work for everybody, but I would certainly want to integrate diet with drugs where I know I have some handle on the whole thing. And that would, to me, would be a more logical way to go about it.
That's exactly where I was going. I'm glad you covered that, though, to compare water fasting versus the treatment protocol we've been talking about.
Yeah. I mean, sure, they can work. I'm not going to, because I have hard evidence that it does work, but it's not something a lot of people are going to jump on right away.
So we've gone into the details of what your treatment protocol would look like with the diet or the fasting and the pulsing of the drug, the DON. I'm curious now, how long, obviously it's going to depend on the type of cancer and how invasive it is and how long it's been there and a lot of different factors. But if somebody is trying a protocol like this, how long typically do they need to do something like this to get to a point when they can, go to a diet and lifestyle to manage the cancer at that point versus all these other things?
Yeah, no, it's hard. It's a good question. I don't know. Well, I mean, what are your choices? Right? I mean, what are your choices? Well, someone could say, listen, I don't want to do that. I don't want to do that for the rest of my life. And the answer is you might not have to do that, but we can't be 100% sure about that. Let me give you an example from one case published, Pablo Kelly, and the other case from an individual that I know from Norway, and he did a big film on this. It's all in Norwegian. Terje from Norway, and we have 2 examples of what the question exactly to address your question. Pablo took no radiation, no chemo, no steroids. His tumor continued to grow for 3 years, slowly. He was in a carnivore kind of keto, mostly meats and stuff. And eventually it grew to the point where he had to have it debulked, cut out, because we all looked and said, this diet alone without drug is not causing your tumor to regress completely. So he had it debulked. First, they said it was a operable tumor. It was inoperable, so you wouldn't be able to get it all out. Then after 3 years of ketogenic metabolic therapy, they looked at it, a CAT scan MRI, and says, oh, this thing might be debulked more completely than it was 3 years earlier. So he said, okay. So he gets the tumor out, and the neurosurgeon, the surgeon said, we think we got most of it. Oh, okay. So Pablo thinks he's out of the woods, goes back not to the same kind of, he was keeping his glucose ketone index pretty good around 2.0 or below. After the debulking surgery, they said, oh, it looks like we got a lot of the tumor out. So he started to transition back to a more carbohydrate kind of diet. And then the next MRI about, 6 or 8 months later, showed growth of the tumor. So put the fear of God in him. And he went right back onto a more restricted diet. And you could see the damn tumor, the images going down. Now, after another 3 years, the tumor was continued to grow and grow, but very slowly, and debulked. So he's had 2 debulking surgeries. He's out over 8 years of survival. He's got married, has 2 children. He would have not had any of that had he done the standard of care up front. So the question is, will he have to use the rest of his life? And so far he hasn't taken Don or embendazole or some of the other drugs that we know can work on this. He's very comfortable the way he's doing. The other fellow had melanoma from Norway. And he could actually see the lesions on his leg get bigger the more carbs he took in. And when he stopped the carbs, he could actually see the lesions going down. I mean, it was like he had the pictures of going up and going down. It's unbelievable. So he said, listen, if I want that tumor out of my body, I got to stop taking these carbohydrates. So he switched over his diet to meats and all kinds of things, but very, very low in carbohydrates. And he's fine. I mean, he's been out years now. And he knows that this may come back, but he just prefers to change his diet and lifestyle so it doesn't come back. And that's the individual choice that people are going to have to make. Does that mean you have to drop out of society just so you don't have your tumor grow? No, it doesn't. I mean, he's perfectly interactive with all kinds of people and conventions and lectures and all kinds of stuff. So, but I think you really probably have to really restrict the kinds of foods that make your blood sugar go up. I think that's the safest way, but you're rolling the dice. And I have no idea whether someone who has managed their cancer for several years without a recurrence, they really feel good about their life, their health, and then all of a sudden they want to go back and enter into a diet that has a lot of carbs in it most of the time. And I don't know what we can say about. We haven't had enough examples and publications to show, let's take 2 groups of people. One's metabolically managed, doing really, really well. Another group that was metabolically managed really, really well. Let's keep these guys on their same diet and lifestyle, and let's let these guys return to the way they were before they had cancer. And then compare and contrast the 2 groups. Who's going to do a trial like that? Think about it.
You talked about the drug when you were talking about Pablo's case. I wasn't sure if he had any of the drug. Did he have any done early on in his treatment?
No. Nothing.
Okay. And in the second case, any Dawn in there at all or no?
No. So we only know Dawn works really well because we have preclinical studies to show that it does. And it works a hell of a lot better on the metastatic kind of cell than it does on the stem cells. Not to say that it doesn't work on cancer stem cells, but we're building these cocktails all the time, diet drug cocktails. And as I said, the 2 fuels are glucose and glutamine. So the diet drug cocktail is designed to keep the rest of the cells healthy while you strategize on how to shut down glucose and glutamine. So some tumors are more glucose dependent than glutamine dependent, and some tumors appear to be more glutamine dependent than glucose dependent. But that doesn't mean they're restricted to one fuel versus the other. It's just that their proportionality of using the 2 fuels can differ. So our viewpoint is, what's the best therapy that will eliminate those 2 fuels simultaneously? And then if we find out there's still some level of growth, because don't forget, as I said, there's many steps in that glutaminolysis pathway that could be targeted with some drugs. And we're still learning about that. So, I mean, believe me, this is not a done deal. We've just opened the door into a world of new approaches for managing cancer. And in the future, we'll be able to build much better diet drug cocktails to take care of all of these outlier cells and all of these kinds of things. We're just telling you that the framework by which the strategy will eventually be built on this press pulse concept. But the physicians, clinics, guys, these guys are going to be the ones perfecting all this stuff when they see the outcome in their treated patients. So it's like anything. You're going to learn diet, doses, timing, and scheduling for various types of people, their body weights, sex, their age, all of these kinds of things must be brought into consideration. How many other diseases do they have besides cancer? I mean, this is another thing. We've seen patients come into the clinic. They have parasite infections. Their blood work looks like hell. I mean, they're all off the metabolic in many different type 2 diabetes, high blood pressure, hypertension. They have all kinds of things. All that stuff has to be brought back into a semi-normal state. And then you strategically use low doses of drugs to target and kill the tumor cells while not putting the patient at a metabolic balance. So again, you really have to be the artisan of the understanding of the human body and how it works, and how best you can fit that patient with the therapy.
So when it comes to published research and it comes to drugs like Dawn and other drugs in that family, is that only been looking at animal models to this point?
Well, there are clinical trials on some of these drugs that are going on right now. The problem with these trials is no one is combining the drug with the metabolic therapy. So they want to see if a glutamine targeting drug has been used in the past. Was it a blockbuster? No, it was not a blockbuster. Does it become more powerful when you put it with the ketogenic? Absolutely. So, but they don't want to do that because they want to get they're looking for. Don't forget, the Food and Drug Administration says if your patients can live an extra 2 months, we'll give you approval on that drug. I mean, we don't want extra 2 months. We want years but they will not do the trial with the ketogenic diet because I was told by several drug guys, we won't know if it's the ketogenic diet or the drug that's making the difference. We got to know if it's the drug. I said, what about the patient? It's got to be, it's not the patient. It's the revenue generation from the drug they make. So again, what's your strategy here? Is it how long can you keep your patient alive? Or is it how are you going to be able to make this drug a blockbuster? None of these drugs are ever going to be blockbusters. I can tell you that right now. The only way you're going to get real powerful therapeutic benefit is you got to know how to use that drug with the appropriate diet to get the full power of what you're doing. And so far, nobody wants to do that.
Given the nature of this conversation, it's going to bring a lot of people to it who have cancer and probably a lot of people who are at a point in their journey where they don't feel like they have a lot of different options and they might be far along their cancer, journey, stage 4 being, one extreme, or people that have other people in their lives that are dealing with cancer and are looking for alternatives. So where I'm going with all this, it sounds like this is all very new and there's not a lot of areas to turn for treatment of the type we're talking about today. There's a lot of roadblocks in people's way. Yeah. So if it was you or somebody that you know in your family that came to you and said, Dr. Seyfried, I want to try this. Yeah. Where do they go these days? While this is so new and there's not a lot of people doing it.
I know. Well, there's some small clinics that are starting to dabble in this stuff. But like you said at the beginning, you could be shut down because you're not following standard of care.
Are you passionate about the groundbreaking and heroic research of Dr. Thomas Seyfried on metabolic therapy and cancer? So are we. That's why we've created something special for you, in collaboration with Johnny Rockermeyer, a German book publisher and translator. Introducing our collection of meticulously crafted books that distill the essence of Dr. Seyfried's work. Dive into the science and discoveries. These summary books are your gateway to understanding the intricate world of metabolic ketogenic therapy in a clear, concise, and engaging way. Whether you're new to the subject or a seasoned enthusiast, our books offer insights that can change your life. Ready to explore this transformative knowledge? Visit our website at www.cancerasametabolicdisease.com to get your copy. You can buy the ebook there directly and the paper book via the provided links. Here's the best part. A portion of every purchase goes directly to support Dr. Thomas Seyfried's groundbreaking research. That's why the direct ebook purchase is the best option to donate as much as possible.
You can see all of the donations Mr. Rockermeyer has already made at www.ketoforcancer.net. That's right, when you buy our books, you're not just investing in your own knowledge, you're also contributing to the future of cancer research. Help us make a difference. Together, we can drive change and save lives.
For political reasons, has nothing to do with the clinical. They're shutting it down because they don't understand it. They don't know about it. But because you're not following protocol, I mean, these poor, as you said, some of these poor guys could lose their license for doing it. You will not see metabolic therapy discussed in any degree at the top medical schools. You got to deal with they never heard of Otto. Many of them never heard of Otto Warburg. Many of them never heard of what I'm talking about. So you have that wall of interference. Yeah, it's a problem. Okay, so how do we get the word? You got to train physicians to know how to use the strategy, the technology. They have to be educated. They can be. This is not insurmountably. Some of the actual into the nitty gritty biochemical pathways supporting what I am saying does take a lot of in-depth knowledge and research. There's no question about it. I'm just able to take it out of the molecular mud and bring it into a comprehensible strategy. But I'm in the mud all the time, trying to clean up what we know and how to improve what we know. But we are already far enough along in case reports and in preclinical outcome to know this is the path forward. We already know that. So if we know that, why are we not going in that direction? Because there are all these other issues. One of the biggest ones is revenue generation. How do we keep everybody's books balanced? It's okay if I can bring in a new strategy to replace standard of care, but standard of care generates a lot of revenue. So how can we use metabolic therapy? Who has the business model? What entrepreneur is going to step forward with a business model? Because everybody's going to be happy if I can earn as much money doing metabolic therapy as I would doing radiation and chemo. But right now that hasn't happened. We're still looking for the entrepreneurs to figure out how to do this, because I think the people want it. The cancer patients want it. The problem is we have this revenue issue that we have to get through, and I'm not that kind of a guy. I don't deal with trying to figure out that kind of to solve that problem. My goal is to show that this will be the future of cancer. It's just that we have to put the other parts of the puzzle together to make it that way. We have to we can set up clinics. All the top medical schools could be doing this right now with a little bit of 6-month training program, knowing how classes and re-education and research. But who's going to make the money on this, right? Where is the money going to come from? I can manage your cancer without toxicity on the cheap. Great. Okay. How is that going to help our industry? I don't know. Somebody's going to have to figure that out. But it's going to happen. You can delay it only for so long, because the more and more people that are using this and the more and more people are surviving a hell of a lot longer they would have been if they had gone to standard of care, is eventually going to be a grass fire, and people are going to say, I want this. You're going to have to adapt in some way because we want it. And we want it. Why? What do you think? Because we understand the biology. We're actually targeting the very essence of what those cells need to survive without the toxicity. And we can do it, absolutely. We already have the drugs. We already have the know-how. We just don't have the motivation to do it. And that's something that I can't address.
For somebody who is desperate enough and determined enough and is tuning in right now, are there clinics out of country? Is there stuff overseas people can look to down in Mexico? If you can't answer that, fair enough, but I just have to push you on it to give people something that have tuned into this point and feel like I'm desperate. And the other factor here is time, especially for people that, might be more towards the end stages of cancer. They don't have a lot of time. So I just feel for people, and I want them to have something practical they can grab onto at the end of this.
You feel for people. Think about how I feel for these folks. I mean, they're coming to me. I get some letters of people that are in the end stage of their disease, and I can't believe that they could still be alive after what they have gone through, in up to the point when they're desperate. They're at their end of their string here. They're going to hospice, for crying out loud. And now they're coming to say, can metabolic therapy be helpful to me? And the answer is, I don't know. I'm not saying, I can't tell people, oh yeah, we have the panacea for your problem. No, I don't. I mean, the issue here is that we have a planned strategy to manage cancer, and it's done differently than what they do in the major medical centers. So it's based on a completely different underlying theory of what the disease is. And again, they always say, if you catch the disease early, you can potentially cure it. That's true for metabolic therapy as well as it would be for standard of care therapy. But as you mentioned, Jesse, you now have to use metabolic therapy to not only try to kill the remaining tumor cells or what's ever growing, but now try to correct all of the massive damage that was done to your body by toxic poisons and radiation, or immunotherapies, or all this stuff. So you're asking a new approach to not only solve the original problem, but to fix the mess that you already went through in trying to use those failed procedures to manage your disease. So this is a real tough thing to expect on an emerging therapy to try to. Now, that doesn't mean those folks can't benefit from this. I have seen the paper we published on the woman with breast cancer out of the clinic in Istanbul. She was from Ohio, advanced triple negative breast cancer to the brain, which is really bad, liver and brain. When you get your cancer spreading to your other organs, especially the brain, it's usually lights out. And they said, there's no more we can do. Well, that woman went to the clinic, and she was in the emergency room for quite a while. She was near death, but they fixed her up, got her back, and she had to go through this metabolic therapy for a couple, 3 months. And eventually she returned back to the United States and is really good. I mean, I know these anecdotal things sound crazy, but we have her doing really, really well. We have evidence what her tumor was, how much it metastasized, how bad it was, and now she's alive and she's looking pretty good. And that's why I think you have to look at the survivors in the movie Cancer Revolution, where Maggie and Brad Jones have interviewed these so-called terminal cancer patients who have rallied. I think the issue is that how healthy is the person? Some of these people say, I've been through everything, and they tell me I only have 6 months left. How do you feel now? Well, I actually feel pretty good. Well, if that's the case, you may be able to adjust to metabolic therapy. But when somebody's calling you from hospice and they're saying, "Can you help me?" It's really hard. I hate to say it, but it's hard. So, and it's hard for anything. They wouldn't be in hospice if something worked in the first place. So, so it's a judgment call, and you have to have a team of physicians that have to make those judgments, work with the patient, with the family, but at least provide them with options and opportunities that they presently might not have. It's always a hard thing to say, well, we've done everything, there's no more we can do. I mean, that's a terrible thing to tell somebody, especially after you threw the kitchen sink at them, spend all this money and all this crazy stuff and that doesn't work. I mean, this is tragic. This whole cancer thing is just a massive tragedy, humanity, a tragedy of humanity.
How do you feel about cancer screenings? There's a lot of different methods out there, mammography, needle biopsy, and we could go on and on. Yeah. If somebody has signs and symptoms and they feel like they might have cancer or their doctor's screening them, what I'm getting at here is there a continuum from, good, better, best when it comes to assessing? And I've heard of things like thermal imaging that are less invasive or supposedly. How do you feel about all that?
Well, I think any kind of imaging that is non-invasive could be potentially helpful. So a non-invasive imaging, like you said, thermal imaging, they're trying to work on blood biopsy, liquid biopsy, which I think the president's moonshot project, I hate to call it that, but he has a component in there for looking more into liquid biopsies, where you can take the blood and look and see if you have certain cancer markers that might predict whether or not you should have a certain type of treatment. But there's still a lot of false positives and false negatives associated with that. I think MRI, PET scan, anything that you can use to get an assessment. My colleagues that work in the area, the radiologists, these kinds of guys, they're pretty sure when they look at an image, not 100% sure, but maybe a pretty high percentage sure, to know whether that mass that you're looking at is malignant or not. Okay. Now, the field determines that in order to make that decision, you need to take a biopsy of the tissue, look at it under the microscope, and then confirm what the radiologist has already predicted. That's malignant, because I can look at the edges. I can look at the image the way it looks in angles, and they can pretty much determine whether this is bad or good, or how bad it could be. But the ultimate determination comes from the biopsy material, where a pathologist looks at the number and structure of the cells. My concern with that is that I have read many papers where the very process of taking sample from the tissue could provoke the microenvironment, leading to a tumor cell dissemination from the very procedure to look at the tissue to determine whether or not it's malignant. Now, if it's a benign tumor, then you would never really need to take a biopsy from it. If you could assess that it would be benign, you can just cut it out and debulk it without really doing much else. But if it is malignant, the last thing you would want to do is take a biopsy of that tissue, leading to the process of now spreading it through your body. And people say, oh, it's very rare. I agree. I didn't say it's very rare. It's not common. Biopsy of patients' tumors to cause it to be a terminal malignant cancer is, in fact, not common. However, there's enough papers in the literature to say that it can happen in multiple different cancers, not only brain cancer, colon cancer, breast cancer, all these different kinds of cancers that I've seen, where they actually spread the tumor cells around from biopsy. Yes, it doesn't happen. It's not a common thing. But what about the poor patient that dies from that needlessly? Okay, for that person, it's lights out. That didn't need to happen. They used to have the morcellation procedure for uterine polyps in women. Okay, they pulled that off the market. Why? Because it's like a kind of a lawnmower. It grinds up the polyps in the uterus. And people were getting metastatic cancer and dying from the grinding up of the polyps. Because if one of those polyps happened to be a malignant polyp, you're spreading the malignant cells all over the place. So they had to stop this morcellation procedure. That was exactly what I'm talking about. So you've got to be very careful. You don't want to stick the hive when the bees are all in and have the bees come out. You got to get rid of it before they can come out. That's why I said, if you see something, go on metabolic therapy, see if it disappears, and if it doesn't disappear and it becomes smaller, debulk it, get rid of it. Don't go and chop around on it, this kind of stuff.
That's what I was getting at. I'm glad you're able to decipher. There's a continuum from bad to good when it comes to screening, which isn't even into the therapy, all the stuff we talked about before, which is another whole area that people have to decipher through and figure out their own path.
You're absolutely right. So everything has to be done strategically, causing the least amount of stress and harm to the patient under any conditions. And again, each patient is different from another patient. And the sharp people who understand screening can make those decisions. If they're trained to know how to make these decisions and then be very careful about their recommendations, I think a lot of people will benefit from this, or at least you won't let some people die needlessly from a lack of knowledge.
To this point, we focused on treatment of cancer for somebody that has cancer and they want to take an alternative path. What I want to end on with you here is for somebody who is in quote unquote healthy shape right now, and what I want to do is pick your brain as somebody who knows the physiology of cancer, what we can do preventatively to live a healthy lifestyle and hopefully not get to the point where we have cancer and have to make treatment decisions that we were talking about earlier.
Yeah, well, everybody likes to talk about it. Nobody likes to do it. Prevention of cancer is something, it's very difficult in our lifestyle, in the Western lifestyle, to everybody's rolling the dice with the hope that they're not going to get cancer. It's diet and lifestyle and our culture that is ultimately responsible for us getting cancer. And not only cancer, heart disease, type 2 diabetes, obesity. I mean, these things are all linked to the same problem, which is poor diet and lack of exercise. If people were really interested in cancer prevention, we would not have an obesity epidemic. Okay? We would not have an obesity epidemic if people were really interested in cancer prevention. If obesity is a major risk factor for getting cancer, why do we have an obesity epidemic? All right, simple question. Why do we have an epidemic of type 2 diabetes? If people were really interested in preventing cancer, because diabetes and obesity and all these things are all linked, making you at a higher risk for getting cancer. Because our diet and lifestyle is preventing us from the prevention strategy, right? I mean, look at the fast food that we have. I mean, you don't even have to get out of the car, and they hand you the food through the window. There's even no exercise to get out. Our ancestors had to work very, very hard to get food. In the Paleolithic period, we had to hunt down and kill animals and skin them and cook them. I mean, this took a lot of energy, right? And there's no carbohydrate in that stuff either. So our Aboriginal populations had no cancer. The great humanitarian physician Albert Schweitzer went into the jungles of Africa and said most people never had cancer. They didn't even know what it was. Eskimos, originally, when they were first looked at, didn't have cancer. They don't eat any. They're all eating, whales and blubber and kinds of stuff, and they never had cancer. Chimpanzees are our closest relatives in biological terms. Never been a documented case of breast cancer in a chimpanzee, and yet now breast cancer has replaced heart disease as the number one killer of American women. What the hell is going on here? So the chimp is living on a diet and lifestyle that he had when he first evolved as a species. We are not. We are far, far from how we evolved as a species. We are now in an environment rich with poorly nutritious foods, very little exercise. We're sitting in front of computers. We're sitting in cars. Okay, there's your risk. So how do you prevent this? Well, we're all not going to go back and live in a cave. So the issue is you've got to know what is the risk factor for cancer, and you got to know how to prevent it. And as I said, if we have an obesity epidemic, that message is not getting out. As a matter of fact, they're blaming our genes on obesity. Our genes are doing exactly what they evolved to do, store energy, because we starve for most of our existence on this planet. We needed to have a good physiology to store as much energy because we had to go through famine. We had to go through a lot of restrictions, harsh environments, and we needed that energy. And those genes evolved over tens of thousands of years to allow us to store energy. Okay. Now we're in an environment where there's poorly nutritious carbs everywhere. People are getting fat and they're getting cancer and they're getting all these other kinds of diseases. So if people were really interested in prevention, there would be no obesity epidemic. The fact that we have the epidemic means that nobody's interested in preventing, not nobody, many people in our society are not interested in prevention. Once you get cancer, what are you going to do for me? Not that difficult.
Well, I think the big challenge is that to prevent cancer, you have to go against a lot of the ways that society is naturally going these days. And you have to do your own research and live an alternative, quote unquote, lifestyle to try and get back, like you said, to the Paleolithic times. And there's a lot against us, and it does take a lot of effort to figure it out, and a lot of conflicting information for people that do decide to get in and do the learning. So I do feel for people, and I hope having these conversations like I do help clarify for people, and I do what I can to help clarify, and for myself and for others, and I appreciate all you're doing in the world too. And this conversation was fantastic. We covered a lot, and I really appreciate all the work you're putting out into the world, and I wish you the best. Thank you.
Thank you. And you have to realize that the research that we do here at Boston College is all dependent on private foundation and philanthropy. So, this is the more preclinical evidence that I get to support this, the more it goes into the clinics and the more we can help people like that. So people can always help us out by supporting some of the foundations and you can find those foundations in the publications that I encourage everybody to read our papers. They're open access. So you don't have to go to a library. You can get them right online. Let them read the papers and see what they think. If people feel it's good, they can email me back and say, I got something better you might want to try in your preclinical system. Sometimes I do, and sometimes I get information like that too.
Well, we're going to link up for how people can donate below, and we'll link up some of the papers. And again, thank you for coming on the show.
All right, Jesse, thank you very much.